Hello and welcome to the great COVID debate, the part 2 of to intubate or not to intubate. In the last presentation, we showed Dr. Tobin's view, which is why we should not intubate early. They told it on the basis that PCL, that is the spontaneous breathing resulting in lung injury, has very limited evidence and it has existed only in the last 3-4 years. And there is no way to monitor whether the NIV is not working. We cannot know for sure that the patient is not responding to NIV therapy. And last but not the least, we have seen extremely high mortality rates in patients who have been intubated. So definitely intubation is killing the patients and it is better to avoid intubation as much as possible. Now let's see what's Dr. Gattinoni's view regarding why we should intubate the patients early. Now, coming first to the physiological aspect, what are we really worried about is the lung injury. For that, we need to know what is the alveolar pressure. But it is not possible to measure the alveolar pressure. So what we do is we measure the surrogate, that is the airway pressure. Apart from that, we need one more value to know exactly the transmural pressure or the pressure that is straining the alveoli and resulting in the lung injury. That is the pleural pressure. So let's see how a normal breath looks like. So this is how a normal breath is. What you see over here is there is a negative pleural pressure which inflates the lung, resulting in a positive pressure inside the lungs and the flow of the air into the lungs. So the net transpleural pressure is positive, which is driving the breath. The negative pleural pressure is driving the air to come into the lungs. So lung injury is primarily due to the transpulmonary pressure, which is the difference between the alveolar pressure and the pleural pressure. So how we measure it is by subtracting the airway pressure from the pleural pressure. Now, this is how a normal breath is. The alveolar pressure is 0 and the pleural pressure is -8. So what we do get is a net +8 of pressure, which is driving the air into the lungs. So as you can see, the transpulmonary pressure is +8, 0 minus -8, resulting in a plus, which is driving the air into the lungs. Next is a positive pressure breath. This is what we see in a patient who is on ventilator, anesthetized and paralyzed. So since the patient has no efforts, the pleural pressure is 1 and what we get is a net positive pressure which is driving the air into the lungs, which is a pressure of +9, and the transpulmonary pressure is 9 minus 1, which is +8. So this is a positive pressure breath which is driving the air into the lungs. Now let's see what happens if the lung is stiff or it has a stiff chest wall. So here you see that the alveolar pressure is 30 and the pleural pressure is 25. What happens here is most of the pressure is getting wasted in overcoming the stiffness of the chest wall. So even though you are giving very high pressures, 30, ultimately the pressure that is getting applied on the alveolar walls is only 5. So every time you get a very high pressure, it doesn't mean that your alveoli is getting injured. So many of the times what happens is a lot of the pressure gets wasted to overcome the resistance or the steepness of the chest wall. Now here is a trumpet player. He's developing extremely high alveolar pressures, that is almost 150. But he's not developing any lung injury. That is mainly because even though the alveolar pressures are very, very high, the transpulmonary pressure remains very low because the pleural pressure developed over here is extremely positive and high. So what you see here is only 10 of transpleural pressure which is being developed. So last, coming to the disease process which we are discussing over here, which is a patient who is on NIV but with distress. So what happens over here is the alveolar pressure that we see that we are giving is extremely low, say around 10, 12. What we see mostly in COVID patients, you're giving a pressure of 10 and 12 where you're getting very good tidal volumes of around 600, 700. But the point is, to achieve that tidal volume or to achieve that kind of a breath, the patient is also developing a negative pleural pressure. So what happens is, if you check the transpulmonary pressure, it becomes 10 minus of minus 5. So even though we are thinking that we are giving very less pressures, but because the patient is in distress and the patient is developing negative pleural pressure, it adds up and increases the transpleural pressure, resulting in lung injury, which we have seen in a lot of patients who have been on NIV developing surgical emphysema and pneumothorax. Now coming to patient developed spontaneous lung injury. According to Tobin, it is a very new phenomenon, but there is a lot of papers which have been published long back. Barash, in this landmark paper published in 1934, showed how spontaneous breath can result in lung injury. Since then, there have been a lot of papers. So to say that PCLE is something which is very recent and cannot be relied upon to be a factor which happens actually is, I think, overstatement. Last argument is intubation kills. Intubation is actually never a treatment modality. Intubation and mechanical ventilation is never going to get your lung okay. What gets your lung treated is the drugs that you're giving and allowing the patient time for the lungs to recover. Intubation just buys us the time by preventing death. Now, the other thing that we listen is NIV patients are recovering better while intubated patients are dying. But then we must remember that any patient who actually crashes on NIV will ultimately get intubated. So you will rarely have a NIV patient who is actually dying. You will have a patient on NIV who is failing the NIV, going to ventilator, and then dying after 4-5 days. So ultimately it's an intubated patient who will die. And rarely you will find a NIV patient dying on NIV. So, and if a patient actually improves on NIV, then probably he has the milder disease process. The next is the risk of pneumonia. It is almost similar whether you give non-invasive ventilation or intubation. It depends on your nursing practice, nothing else. And also the patient's own risk factors. Lastly, it is the disease process which is actually killing the patient rather than intubation. Intubation just allows us and buys us time by preventing lung injury and maintaining the oxygenation, while the disease process is something which will be based on patient's own response to the COVID virus. Now, can we monitor patients on NIV? How to decide when to intubate? According to Gattinoni, we can measure the esophageal pressure, and a pressure swing of more than 14 would result in lung injury. But that would not be a very practical thing at the bedside, especially in the pandemic situation. So we can monitor tidal volumes. If you are getting very high tidal volumes and very high respiratory rates, it actually indicates the patient is in distress. You can also look for the use of accessories. If the patient is having these features, then it can be taken for granted that definitely there is a higher driving pressure and which will result in lung injury. So the take home message would be, if the saturation drops with oxygen, try high flow nasal oxygen and NIV. Do monitor tidal volume and respiratory rate. It is difficult to tell the ideal time for intubation, but the ideal time of intubation according to us is when you actually think there is a need for intubation. Do not unnecessarily continue up NIV thinking that intubation is going to kill my patient, or NIV the patients are recovering more. It is not going to work like that. So if you're having patients with high tidal volumes and respiratory rates who are in distress even on NIV, it is better to intubate these patients rather than carrying on with NIV thinking that it is going to take the patient out. So thank you for your patience, and check our website for further information.